Hi everyone, this is Professor Lovell, and today we are talking about systems of health and medicine. Um, i- in addition to science, we'll be going through Quadagno's work on the healthcare system in the US, as well as how science has constructed the sex binary. Um, you are also assigned the textbook to get caught up on various definitions and concepts for sociology of health and medicine. Use the discussion boards if you have questions about those, as well as a piece on offshoring clinical trials. That is a great example of sociology looking at systems and how they work, especially systems that we don't often understand unless we are part of the system. So read that loosely. You will not be tested on it, but it's a great example of how sociologists do systems work. Okay, so let's start with the US healthcare system. A couple of facts that healthcare is one of the largest expenses in the US, that 20% of the GDP in the US is spent on healthcare in some way. Now, GDP is a calculation of all the expenses by companies, by individuals, by the government in a single country, and that means 20% of all expenses in the US were on healthcare. Um, in total, this was around $4.1 trillion dollars. And so healthcare is a huge business and it's a huge industry and it's a huge system. Um, it also has a lot of problems. Two-thirds of all bankruptcies in the US cite healthcare costs as the main issue. And about 700,000 people in 2019 alone filed for bankruptcy due to medical costs. That number has likely risen, especially as the pandemic has hurt more and more people. Now, the US spends more per capita on its healthcare. So, about um, taking all of the money in the US and dividing it by the population, that comes out to about $10,000 per person. That is far more than Switzerland, which is around $7,000 per person, as well as France, Canada, Australia, and the UK, which are all between $5,000 and $4,000 per person. Yet, despite spending twice as much as many of the other industrialized countries, we have the worst outcomes. On the right, you see that the life expectancy at birth for the US is 78.5 years, while all the other countries here are above 80. So the amount of money we're spending on healthcare is not returning to better results. Another example of this is a data set that's looking at the number of preventable deaths if healthcare was available for these industrialized countries. And so this is the number of deaths per 100,000 people. We can see that on the low end, we have Switzerland, France, and Austria, which are hitting around 60 um, preventable deaths per 100,000, whereas the US is far above 100, hitting 120 preventable deaths per 100,000. So almost twice as many people are dying um, because they do not have access to healthcare than the other countries in the industrialized world. So when we look at systems, often we look at systems to focus on problems like this. Why is the American system, so to speak, creating so many deaths despite having so much costs? And so that's what we'll be looking at today in this part of the presentation. Using Quadagno's sociology of healthcare reform, she gives three important parts to the system of healthcare in the US. The first, she's looking at institutions, and she divides this into care delivery institutions and financing of care. So, care delivery is simply the institutions that are actually providing healthcare, like hospitals, like a private practice for your doctor, like an ambulance or a urgent care center, right? Those are the care delivery institutions. Financing of care are all of those who are paying for the for your health care, whether that's you, whether that's private insurance, whether that's the state or the government, some kind of other agencies. And using these two institutions, a lot of investigations have been done to see how different countries organize care delivery and finances. And in this, we're going to look at the results of a study by T.R. Reid, who went around the world to see how different countries set up their healthcare models. If you would like, the Pitchfork Economics interview is a podcast. It's around 30 minutes. It's a great way to get a lot of information about the healthcare systems around the world and how they compare with the US. He also made a documentary with the PBS. It's about a little bit over an hour, and the link is here in the presentation. What T.R. Reid found was there are four basic healthcare models around the world. The first is what people often mean when they talk about socialized medicine. This is in countries like the UK, Cuba, most of the Nordic countries like Sweden, Finland, Norway. This is when the government both runs the care delivery, so the actual healthcare, and the government runs the payments. So in these countries, you usually have higher taxes, but that's because you rarely pay medical bills. For example, in the UK, dentists are still privatized, but all other healthcare is public. So this is an example where the government does both care delivery and finances. On the other side, you have countries like Germany and Japan that have it completely privatized. It is required that every single person in the country have privatized insurance and access to all private healthcare companies. The government will subsidize a lot of the payments for various, income levels, but everyone is required to have insurance and healthcare, and that is run all through private companies. So this is kind of something similar to what Obamacare tried to do in the US with the mandate to have insurance, was putting everyone on a private insurance. And these ones work so both the full public and the full private have cheaper healthcare and better outcomes in the US. So about 40 cents for every American dollar is spent in the UK, and they have much better health outcomes. In Germany, it's about 60 cents for every American dollar spent on healthcare. So again, it's about a third cheaper in Germany. There is another kind of model that does it split. This is seen in Canada, Australia. This is when you have private run healthcare, so the doctors are run by private companies, but the government runs the payment. So the government will pay for the insurance. So you have a public-private model comparison. Again, this is also cheaper than the US. We know that there are criticisms of Canadians, Canada's healthcare model, in that there's long wait times, but it seems to work in other countries like Australia. And then no healthcare model is usually in poorer nations where everything was private and there is no government mandate to have insurance or to have healthcare payments. And thus, a lot of it is only for the wealthy in each nation. T.R. Reid says, what is different between the U.S. and these main three models is that the countries have all decided that every citizen should both have healthcare and have the ability to pay for it. And so whether or not it is government-run healthcare, private healthcare, or if it's government-run payments or private payments, what is important in each of these countries is that everyone is healthcare is seen more as a right rather than as a privilege. In the no healthcare model, there is no guarantee to healthcare. Now, when we think about what about the US? We often hear about public versus private. In the US, we actually fit all four. So if you are a veteran, that is a full public model where you have US run healthcare facilities, hospitals, physicians, and you have all of it is paid for by the government. However, if you are an employee of a private company, usually you are going to private healthcare, private hospitals, and you're using private insurance. If you are in poverty or if you are elderly, you will qualify for a public-private model where you go to private healthcare facilities, but the government will pay the insurance. Yet there is still a large amount in the US that still has no health care at all. So about 26.1 million people in the US still do not have health care. So T.R. Reid actually argues that one of the problems with the US healthcare system is not just that as a nation we have not decided that everyone should have health care, but that we have a patchwork connection of systems that work in so many different ways, and it is so confusing to go through each of these kind of models. And he argues that whether it is we go full public, whether it is we go full private, whether it is we go public-private, doesn't matter. It's just that we need to have a system that is consistent for everyone and has the dedication to making sure everyone has access to healthcare. So for Guadagno, this is the institutions. This is how sociologists would look at institutions. She also says that we need to focus on how is healthcare focused, or how does it have an ideology? How does it have a norm of a belief in which healthcare is either a right or a commodity? So those three models that are full public, full private, or public-private, what was important about each of these was less how they do it and more that it is a commitment to making sure healthcare is a right. So that would be the social solidarity ideology of healthcare. In the US, we see the market principle largely as the dominant ideology that healthcare is a commodity to be bought and sold. And so if we think about in the US, since it is fairly broken up in different systems, who has the right to healthcare? Well, it is veterans, it is people who are elderly, people who are in poverty. Those are people who have a right to healthcare by law. So this means that the US categorizes people by different values, whether or not they believe you should be taken care of or can be taken care of, and whether or not it is the private industry's responsibility to take care of you instead. So there is an interesting question to think about. How does this ideology affect healthcare in the US? And the third thing that Guadagno says we need to look at are interest groups and social movements. One of the biggest differences between the US and other countries is our lobbying. And in the US, we have pharmaceuticals, healthcare industries, and the medical sector is one of the largest lobbying industries to Congress. So we have pharmaceuticals and insurance are the top two. Hospitals and nursing homes come in the top 10, and health professionals and health services are around number 12 and 13 in terms of the top lobbying industries. And this has created a lot of problems. T.R. Reid gives an example of when Obamacare was being passed. One of the things that the insurance companies were able to put into law was that they are able to charge up to 20% of the healthcare costs as administrative costs. So that's 20% of when you have a bill, they can add on a 20% admin charge, and that goes directly to the pockets of the insurance company. Now, other countries have put a cap on that. So, for example, in Germany, the administrative cost cap is 5%. And in the US, when you look at Medicare, administration costs are only around 2.1%. So the way that insurance companies were able to lobby the law to be able to tack on an additional 20% has really increased prices and costs in the US. Now, besides interest groups, there's also social movements. And throughout history, we've had a variety of social movements that have pushed healthcare to focus on different diseases or make access more possible. This is an example of the AIDS epidemic during the 1980s to the 90s, and getting the US government, state governments, medical agencies to take AIDS seriously rather than assume that it is okay that gay men be killed. Especially to now, this same kind of activism is necessary because AIDS is often seen as a gay disease still, yet the people who suffer from it most are largely in poor income communities. And there is medication to cure it, almost cure it. If you're interested in what kind of medication that is, I'm happy to talk about it more. We also have a long history of civil rights pushing for healthcare reform. The Black Panthers were the first organization to really study and track sickle cell anemia. Civil rights movements were the ones that pushed for desegregation of hospitals. And currently there is movements to help make healthcare affordable and accessible for immigrants. When it takes 15 plus years to become a legal immigrant, many of these folks are left without health care for years. Okay, I'm going to leave these slides for you to go over on your own. It should help spurn some ideas in terms of how to think about interactions, relationships, hierarchies, norms, and behaviors. Remember, these are all the parts that go into systems, and it's important to think through these and to be able to identify how the system works as a whole. So this is a pretty important slide to go through on your own. I also have a couple of slides added to this that will help you. Here are some examples of arrangements of interactions. Here are some examples of networks and relationships. Again, these slides will be on the Blackboard as well as this. Let's move instead into the system of So let's move into the system of science. Sorry about that break. This is being pulled from Sansa's No Way Out of the Binary. So if we think about what it means to be male or female, we often look at these characteristics, whether it's the anatomy, the gonads, the hormones, chromosomes, the genes, or different kinds of brain or psychological traits. So when we look at anatomy and psychological trait, this is often what we're seeing. Sensitivity of women versus the dominance of men, that women are more likely to get depressed, whereas men are more likely to get angry and aggressive, right? These are kind of ways that psychologists and other scientists typically determine who is male and female. We also look at external traits like breasts, like shoulder width, like height, like large hands and feet versus small hands and feet, voice, whether you have a deeper voice or a lighter voice, etc. What Veronica Sands is saying, that often these are based on statistical tricks that don't really explain the variety within each sex and between sexes. So to give a little background to this, a histogram is a chart that measures the frequency of a variety of cases or observations. So in this chart, researchers measured the height of 1,000 people, and then if you look at the bottom of this chart, It has the height in centimeters from around 145 all the way up to 185. And for every person, they added a little tick, a little height in that bar. And so when it says density, that just means the percentage of overall um, of the data set. So this is saying that someone who is right under 165 centimeters, that's about 8% of the data set. So about 80 people are in this box right here. And then when you look at the one above it, that's saying it's about 75 people, so 7.5%, etc. And so they map these counts and they can see a normal, like a little curve, right? When you kind of smooth it out. This is called the normal curve. Why it's called the normal curve is because these values in the center are what scientists argue, because they're more common, are the norm, the average, what should be. And so what scientists do is, instead of reporting on this whole range of values for height, they will just be looking at this norm, so this middle number here. And that's how they describe the difference between men and women, right? So here they have all of the women lined up and tabled into this pink graph, and then all the men lined up and labeled or tabled into this blue graph. And then they find the middle number, which for women is 5'4" and for men is 5'9.5". And they say, look, there's a 5-inch difference between men and women. Now, what Veronica Sands is saying is that, well, wait a second, look at all of this overlap. Men and women are more likely to be the same height than they are to be vastly different heights, right? So it's really inappropriate to say, oh, there's this big gap between men and women's height, when for the majority of the US population and the world population as a whole, the height will be similar. Okay? So the overlap is often disregarded in favor of showing the median to argue that there is a big difference between men and women. And this isn't just for height, but it's for all of the personality differences, for and all of the other physical differences. Now, when we look at gonads, this is another paradigm by which scientists try to differentiate between men and women. The gonads are those organs that produce the reproductive cells. So it's either the testes or the ovaries. Problem is that many people are born with both or with neither. If they are born with both, that is called ovotestes, in which they have both a testicle and an ovary. And even more complicated is that both the testes and the ovaries are from the same exact tissue. And that makes it complicated in determining which one it is, even at an older age. There is a condition called huevadosis, which is directly translated penis at 12. And this is fairly common in Dominican Republic, where many of the children are born with a vagina and ovaries, but then at age 12, it shifts to the organ that what they thought were ovaries drops into testicles, and the person grows a penis. So how do you characterize men and women when even over the lifespan for some people there is a change? Now, Veronica Sands next looks at how people use hormones to try to determine men and women. So first, we've often hear that men use testosterone and women have estrogen. But she makes the point that these are actually families of molecules and of carbohydrates in our body, and that men and women both need all of these, right? So on the right, you have different kinds of androgens. On the left, you have different kinds of estrogens, and that men and women need both. In fact, for men, if you have low levels of estrogen, you have trouble with your sex drive. For women who have low levels of androgens or testosterone, you have trouble with your sex drive and with your brain functioning. So both of these are necessary for both men and women. And why do we separate, men and women by their hormones? Even more complicated is that testosterone can morph into estrogens. Depending on one's bodily need and the social situations in which one lives, testosterone or androgens and estrogens can morph into one another because they are just, protein chains and can add different molecules to become a different compound or molecule. I think it's a molecule. A paper in 2015, some scientists tried to test this to see if social situations do change our testosterone or estrogen levels. And they took some people and they divided them, men and women, and then they put them in a situation where they had to act like a boss for a day and go fire people. First, they had to fire people in a masculine way, so being very cruel, very angry. Then they had to fire them in a feminine way, being very kind, being very understanding, trying to help them. And then they had to just exist as a regular person, so not being a boss. And when they did this, they found that women's testosterone spiked, regardless of whether they were acting as a boss femininely or masculinely. Their testosterone spiked while being in the position of power. Testosterone also spiked for men, although not as much because they already had some testosterone. So some researchers believe that the reason there is such a difference in terms of estrogen, that like the median estrogen and the median testosterone of men and women, is more because of the social situations that they have been put in over time rather than a biological hard fact. Next, one of the ways that scientists have tried to divide men and women and scientifically prove the difference is by chromosomes and genes. So here on the left, we have the human karyotype, which is the collection of chromosomes that make up a person's genetic code and that either have, for their 23rd chromosome, a XX or XY that determines whether they are male or female. However, that geneticists and biologists have found so many different kinds of possibilities. There could be an XXY, there could be no X chromosome at all. There could be an XXX, there could be an XYY. As scientists has found that up to 27 different combinations have been found in human species. Geneticists have also found that it is not only the XX or XY genes that are determinants of sex. Other chromosomes have effects on whether or not someone will produce eggs or sperm, or whether they have a penis or vagina, or etc. And so it is hard to say that there is one single answer to determining one's sex. Further, one person can develop cells that have both XX and cells that have XY chromosomes. So here on the right, we have someone who has developed various areas of their body exhibit XX chromosomes, and so they are quote unquote female parts of the body, whereas other parts have XY chromosomes. And so who is this person? Is it a woman or a man? What these examples show us is that it is very hard to distinguish between men and women, and all of the ways in which we have done so has some problem with it. And so Sands argues that we have developed an assumption of a binary, and we've made science fit that binary. Even though science progressed through a series of stages to try and prove the binary, exceptions and challenges have always arisen. So she concludes that despite all the dead ends and the past and current controversies about the supreme variable to determine sex, something has remained unchallenged since the birth of biology in the 18th century. This is the assumption of the dichotomous character of sex. So she's saying that throughout all time, The only thing that has not changed is that we assume sex. We assume it, and so we look for every way to prove it. So this is an example of how an ideology can influence even our hard sciences, even biology, chemistry, etc. And that we need to check our assumptions in order to produce a more value-free science. That concludes the presentation. A note on the MGPs, I'm not looking for perfection. I'm just looking to see if you followed the process of a college level essay. So when you get your feedback from the Writing Center, I'm not expecting you to make this into the best final product you've ever had, but making sure that you look at the comments from the Writing Center and incorporate that into your final revisions before you turn it in. Okay, please let me know if you have any questions. Otherwise, we will see you next week. Thank you.